Now, today I'm going to talk to you on Chikungunya, acute arthralgia to chronic disability. And Chikungunya, as we all know, is an alpha virus. And it's an RNA virus, and it belongs to arboviral family. As we all know, the vector is Aedes aegypti and Aedes albopictus, which is the common vector for dengue viral infection. And incubation period, everyone know, 3 to 7 days, and it presents as acute febrile illness. The disease was first detected in 1953 in an African country, Tanzania. According to their language, the meaning of is tends to fold up with stoop posture due to severe arthritic manifestation of chikungunya infection. That itself suggests us the impact of the disease on the patient as well as society. Next 20 to 30 minutes, I am going to tell you about chikungunya epidemic in our country. I'm just going to briefly tell about the previous chikungunya epidemic in our country, and I'm going to discuss a few case scenarios related to current epidemic, and I'm going to just tell you musculoskeletal manifestations of chikungunya infection and challenges as physicians we are facing in diagnosis and managing musculoskeletal manifestations of chikungunya. The first epidemic, Sri Lankan epidemic, has documented in early 1960s. As Dr. Munisinghe suggests, in 1966, it was sort of a febrile illness, but in that epidemic, the arthritic manifestations were minimal. But we had a huge epidemic in 2006. At that time, I was a physician at Mavanella Hospital. More than 40,000 of patients were infected with chikungunya. And I have one study which was published by Shamsi in 2014, where he investigated clinical features of chikungunya fever outbreak in eastern province in Sri Lanka in 2006. And he has recruited more than 700 patients, and about 67% of patients suffered from chikungunya illness and its manifestation more than 2 weeks. You can understand the gravity of the illness. And he has noticed females were more affected than males. And presenting complaint in that epidemic was fever, skin rash, buccal bleeding, mouth ulcers, vomiting, large joint arthralgia, and arthritis. In fact, this author suggests that Sri Lanka need to understand the epidemiology of this disease in every region in view of developing and implementing rational national policy on its prevention and control. Today, have we addressed this issue after 2006 and 7? Again, we have an epidemic. Why we have an epidemic? Whether it is due to failure of us or whether the virus has become more virulent. In this regard, in 2024-25 epidemic, this virus strain has been identified by Professor Lilika Malavidi and her team, and it is the Sri Lankan viral strain belongs to the Indian Ocean lineage as in other Southeast Asian countries. And this has very different bizarre presentations. They present with acute febrile illness, arthralgia, but notoriously they have extra-articular manifestations such as encephalitis, optic neuritis, uveitis, facial muscle weakness, myocarditis, and various multi-organ involvement. I think most of our speakers are going to discuss today. But still, we don't have enough documentary evidence, and we are waiting for documentary evidence. So, India also one of the countries which was hit by this current epidemic, and doctors in India has observed alarming leaking with unusual chikungunya infection. We are not sure whether it is true leaking or co-infections with dengue, because it's so common for us to get combined infection, which needs further evaluation with proper virological studies. In this background, I am going to talk to you on few case scenarios which we have encountered during this epidemic. He is 30 years old male who was admitted to medical casualty first week of January 2025 with acute febrile illness, acute arthralgia involving large and small joints, and he also had nausea, vomiting and faintishness. He's a farmer, but he has not engaged in farming activities for last 3 months. Examination, other than tachycardia and mild tendinopathology, rest of the examination was normal. As physician and doctors who work in medical units, we always think about few differential diagnoses in such presentation, whether this is dengue or whether this is leptospirosis or whether this is any other atypical viral infection. With the differential diagnosis, we did few investigations. When we got the investigation results, the patient had neutrophilia, mild to moderate thrombocytopenia, and the CRP was 80, and liver functions revealed mild elevations of SGPT and SGOT, and renal functions were normal. Now, this clinical picture with neutrophilia, low platelet, high CRP, we had to think about the most probable diagnosis as leptospirosis. And we have done NS1 region, it was negative. So we have managed this patient as uncomplicated leptospirosis. In fact, after 3 to 4 days, we were able to discharge the patient. As usual, we asked our patients to come after 1 week for a review. So he came after 1 week. In fact, he couldn't come inside the ward. He couldn't walk properly, and he has bilateral ankle joint swelling, which is not common with dengue or leptospirosis. His leptospiral antibodies were negative. Then only we thought whether we have managed this patient who has had chikungunya with secondary presenting with subacute arthritis. We did EDSR, it was 60, little high, and chikungunya IgM antibody was performed, it was positive. So this patient in the first week of January presented with chikungunya and later presented with subacute arthritis of chikungunya. The second patient, in fact, second patient is a female. I don't want to tell the name because I am the person, but I am not young as my registrar of Sevande, but I am not old. Therefore, I am not going to tell my age. So, 2 weeks ago, in the morning on a Thursday, I woke up, but I couldn't walk. You know why I couldn't walk? I couldn't walk because I had bilateral heel pain. As a physician, I want to find out what was happening to me. Then I had severe Achilles tendinitis and symmetrical polyarthralgia. But I was okay, but I couldn't walk, but I could eat, I could drink, but I couldn't go to work. So, towards the evening, I felt a little unwell. The night, I had very high fever, nausea, vomiting, faintishness, everything under the world. I was very ill, and I spoke to my friend. Then we decided that now this is 2 weeks ago. We are very familiar with chikungunya. I thought I have got chikungunya with Achilles tendinitis. The following day morning, I thought I am going to my ward and going to get done in further investigation. So, but I couldn't come. I couldn't walk. I couldn't walk at all. In fact, I couldn't go to the laboratory. So I asked one of my nursing colleagues, whom I known for a long time. He came and took blood test. So these are the results of my blood test. So there was neutrophil leukocytosis, and I was very scared of dengue, and dengue antigen was negative, and the CRP was more than 100. And for this particular case, my case, somebody would have thought I have sepsis. But with our experience, with my colleague, I thought I am not going to do any other investigation. I am going to rest, take plenty of fluid, and I want to take analgesics. And I thought I am having chikungunya with bilateral tendinitis. It took 1 week for me to recover. And after 1 week, I did chikungunya antibody. It was positive. And the next patient also known to me, he is a physics teacher in a leading school in Kandy. He is 48-year-old. He came to my clinic with difficulty in walking. In fact, he couldn't walk without support. And it is due to swelling of both ankle and no joints with impaired activities of day-to-day activities. He couldn't go to his work. He couldn't do his day-to-day activities. And when we have a patient, as a physician, we always go through entire history to find out a probable diagnosis. So nothing was there. But when I asked direct questioning, he told 2 weeks ago he had a febrile illness and it was treated by GP. After that he was okay. On examination, everything was normal other than arthritis of ankle joint and knee joint. And this particular patient, probable differential diagnosis, what we considered was whether this is chikungunya with subacute arthritis, whether this is seronegative arthritis, or whether it is para-4 rheumatoid arthritis. These are the differential diagnoses what we considered, and we did few investigations. His ESR was high, and the rheumatoid factor and anti-FCCP antibodies were negative, and chikungunya IgM antibody was positive. As you can see, diagnosis of chikungunya in a medical unit, we have to exclude common acute febrile illness like dengue, leptospirosis, COVID, and influenza, as we do not have bedside virology testing for the diagnosis of these chikungunya patients. If we have facilities, we can get done PCR assays within 7 days of infection, and after 5 to 7 days, we can perform chikungunya antibody IgM. It is remained positive more than 3 months, less than after 3 months, and chikungunya IgG appear after 1 week and remain positive after that. So with this background, now you can understand this chikungunya viral infection has 3 phases. Acute febrile arthritic phase, where you get this phase day 1 to day 14. Subacute arthritic phase, which starts after 2 weeks to 12 weeks. Chronic arthritic phase, which lasts more than 3 months. And according to the world literature, prevalence of arthritis in chikungunya is around 40 to 59. If we are going to think about chronic arthritis, the development of chronic chikungunya arthritis, think about me. I am more than 45 years of age and I couldn't do viral load, but my CRP was very high. I have very chance of getting chronic chikungunya arthritis if my T-cell mediated immunity is not going to work properly. I wish that I have a very good, very balanced T-cell mediated immunity, and I am not going to get chikungunya, chronic arthritis in the future. That is my wish. But who knows? So acute arthritic phase. Acute arthritic phase, you get arthralgia. It is distal, symmetrical, involving hands, wrist, shoulders and ankle. Sometimes atypical arthritic pain also could occur. 2 to 3 weeks ago, we had one patient who presented with febrile illness 2 weeks ago with sternoclavicular and joint pain. And temporomandibular joint pain is not that common according to the literature. If you get chikungunya in acute arthritic phase, nothing else other than supplemental treatment, rest, hydration, and paracetamol. We have to always avoid non-steroidal anti-inflammatory agent until dengue is excluded or until we know the platelet count. And we don't recommend steroid use in acute phase in chikungunya infection, because according to the global literature survey, it is better not to use corticosteroids in acute phase due to its immunosuppressive risk, potential adverse effects, lack of proven long-term beneficial effects for arthralgia, and risk of rebound pain after withdrawal of corticosteroids. Even the Sri Lankan guidelines do not support use of oral corticosteroids in acute arthritic phase of chikungunya. What they suggest is paracetamol, NSAIDs, if necessary, gabapentin or codeine. But if your patient is having severe symptoms, you can manage these patients as outpatient. It is better to admit not only patients who are not responding, patients who are pregnant, better to ask them to get admin, and also high-risk group of patients like patients with diabetes, coronary artery disease, and chronic obstructive pulmonary disease. They are more prone to get non-arthritic manifestations of chikungunya infection. Therefore, it is better for them to get admit if they have acute arthritic phase of chikungunya. So with that, now I move into subacute phase after 2 weeks of chikungunya infection. This time, the patients can present with various types of arthritic symptoms. Here, the management is focused on controlling arthritic pain, reducing inflammation, and preventing progression into chronic phase. In the subacute phase, it is very important to quantify the pain and functional disability and decide on overall management. So, to quantify the pain, we use visual analog scale where we give 0 mark for no pain, 10 marks for severe pain. It's very important in managing subacute arthritic phase of chikungunya. And according to every guideline, they ask us to start paracetamol. In fact, I improved with paracetamol, but most of our patients don't improve with paracetamol. Sometimes we can combine with codeine or gabapentin. And this group of patients, we can consider corticosteroids if your patients are not going to improve with this pain management. So recommendation for corticosteroid is if the VASCO is more than 4 to 10. And prednisolone is the recommended drug, and we can start with 10 to 15 milligrams per daily, and we are going to taper the dose every 2 weeks. But when we are tapering the dose, we have to closely monitor recurrence of flare-ups because it's common to get flare-up when we are tapering the dose of steroids. We can use intra-articular corticosteroids for resistant sinusitis and bursitis, and disease-modifying anti-rheumatic agents are not recommended in this age. So we have a nice published study in 2021 in Pakistan Armed Forces Medical Journal. This study studied about use of intramuscular methylprednisolone in subacute phase of chikungunya arthritis. And initially they have treated these patients with 2 weeks of treatment with non-steroidal anti-inflammatory drugs. Then they have measured the pain relief 0, 2 weeks and 4 weeks. According to their conclusion, a single dose of IM methylprednisolone is a rapidly effective, low-cost treatment for post-chikungunya arthritis. Steroids are more effective than NSAIDs in symptom relief. And further, they have noticed the post-chikungunya arthritis closely mimic rheumatoid arthritis, and chikungunya virus may potentially trigger autoimmune process. With that background, I am moving to the last phase of chikungunya, chronic arthritis, chronic chikungunya arthritis. Chronic chikungunya arthritis phase follows a pattern almost similar to rheumatoid arthritis, seronegative arthritis, undifferentiated inflammatory arthritis, and fibromyalgia, which is a common pain syndrome. The pathogenesis of chronic chikungunya arthritis is said to be due to dysregulated T-cell mediated immunity stimulated by the presence of virus in the synovium through induction of autoimmunity causing release of pro-inflammatory cytokines such as interleukin, tumor necrosis factor alpha, and other pro-inflammatory cytokines causing chronic inflammation, joint deformity, and disabling arthritis. This is the simple basis of chronic chikungunya arthritis in a joint. And there are various studies, more than acute arthralgia and subacute arthralgia. We have enough evidence in the literature. The pattern of joint involvement in chronic chikungunya arthritis. And one study says post-chikungunya chronic arthritis commonly shows symmetrical periarticular pattern with morning stiffness, raising the suspicion of possible underlying autoimmune triggering pathology. And during chronic arthritic phase, patients may develop joint deformities and depression similar to rheumatoid arthritis, and fibromyalgias and other rheumatic diseases are also common, similar presentation as in chronic chikungunya arthritis. And there's one study which I would like to pay your attention. It's a Colombian study. They have followed their chikungunya patient for the development of chronic chikungunya arthritis. There they have seen 21% of patients progress to seronegative rheumatoid arthritis in 1 year. 37% of may flare up underlying degenerative arthritis. 35% relapse of previously inactive spondyloarthritis, and 7% may develop fibromyalgia, which is a chronic pain syndrome. Chronic infection is associated with active post-immune system. But according to available data in the literature, there's lack of licensed vaccine or effective medication available against chikungunya virus. Treatment is mainly symptomatic with non-steroidal anti-inflammatory agents and disease-modifying anti-rheumatic agents. In chronic arthritis phase chikungunya, it is very important for us to check for arthritis serology such as rheumatoid factor and anti-FCCP antibodies and HLA-B27, as there may be coexisting rheumatoid arthritis or psoriatic arthritis. Management aims to achieve functional improvement and to improve quality of life with persistent joint involvement. In this regard, these patients should be managed by a rheumatologist, particularly if symptoms are prolonged or worsening. There are criteria, even in Sri Lankan guideline, there are criteria for rheumatology referral. If you have a patient with joint symptoms more than 3 months or recurrence of arthritis following steroid tapering are the indication for referring to a rheumatologist. And these patients will be started on disease-modifying anti-rheumatoid agents such as hydroxychloroquine, methotrexate, leflunomide, and they may start low dose of steroids as well. And most of the time, they do not recommend monotherapy. Combination therapy is strictly required for effective disease control. In addition, this is a chronic arthritic process with impaired activities of daily living. It is very important to involve physiotherapists, occupational therapists, and psychotherapists to give holistic care. So, in summary, I have told management of acute arthritis with evidence-based medicine, management of subacute arthritis with evidence-based medicine, and chronic arthritis. And whatever we do, our experience, more than half of our patients, we find difficult to manage this acute arthritic pain in chikungunya and which need further clinical studies. Thank you very much.
Thank you very much, Madam, for that interesting session. Our next speaker is Dr. Thushari Wanigaratne, specialist in internal medicine at the National Hospital, Kandy. She will explore the dermatological aspects of chikungunya in her talk titled Not Just a Rash. Over to you, Madam.
And it's my pleasure and privilege to talk to you today a very important and inquisitive topic. Cutaneous manifestations of chikungunya are often under-recognized, yet they provide vital diagnostic and prognostic clues, highlighting that it's truly not just a rash. If I tell you, the skin could tell us more about chikungunya than the joints. Let's explore how this virus writes its story not just in pain, but in pigment, peeling, and pustules. So let's see, to start with, there's a slight overlap between Dr. Athauda's facts. Right now, when we start with epidemiology, as she said, first epidemic observed in 1960. And then, since then, it was very silent disease. And 2006 to 2008, you observed the second epidemic in Sri Lanka. And then up to 2020-25, we have not observed any increased number, a part of sporadic cases and small outbreaks. So currently, we are experiencing ongoing epidemic of chikungunya. Again, a little bit of a repetition. When we think of this new virus, Dr. Nilika Malavige and also some other physicians has done the genomic analysis or genomic sequencing of this chikungunya virus. What they have found is you have this chikungunya virus, the current strain which is spreading chikungunya is similar to the strain you see in all Southeast Asian countries, Indian Ocean islands. The subtype is called Indian Ocean lineage. But why this different clinical picture? They have found certain different mutations in the current strain, newly evolved sublineages. These mutations has caused newly evolved sublineages. As a result, these new with these mutations, it enhances viral fitness in Aedes albopictus mosquito, as well as broader and atypical presentation, these strains manifesting, and we are encountering these new viral strains where we get many numbers, and we are now in an epidemic of this chikungunya. So when it comes to chikungunya and skin involvement is usually 40 to 75%, and most common rash, your morbilliform maculopapular rash, but you can get other types of rash as well, pigmentation, after and other skin changes. So I will talk to you regarding the acute manifestations, the skin rashes and the skin involvement, convalescent phase skin involvement, and also other lethal skin involvements. But keep in mind, there's no hard and fast demarcation in the time factors. Always these skin changes can overlap. So this is our patient. Patient presented with day 3 fever and arthralgia. So here this patient is in 3rd day of fever. So we have seen these viral exanthematous fevers. The rashes where in dengue you see in a later phase. In typhus you can see in the early phase. So here what you think of this rash is a morbilliform rash where you see in acute phase. I think most of you have got chikungunya. You can see this type of a morbilliform rash in various degrees in patients. And then your skin erythema, you can see this hand here. It's a very congested or very hyperdense, the hand here. It's like polycythemia for us. This is the skin erythema you get. Sometimes you can get in the face as well. Sometimes you tend to think whether it's a leprosy with our post facial features. So this comes early, as again we have seen many patients, and along this with that, this can be itching, and even without this erythema, your whole body gets started itching with a mild viral symptoms. At that stage, you might not encounter high fevers. So skin erythema and skin itching, and mouth and genital ulcers. That also a very common presentation where we have broad differential diagnosis and difficulty in diagnosis in correct way, as well as going for a wrong diagnosis. You can get these painful ulcers in your scrotum, penis, or else mouth ulcers, where you tend to think where it's a herpetic ulcers, sometimes Stevens-Johnson's. We had a patient recently. Patient has had admitted with febrile fever, and then patient been undergone a catheterization and coming with balanitis with skin ulcers, where patient has lot of concerns. But then with referrals, patient think this is more towards the rubber allergy, but it is not so. When you think of these ulcers, always you have to think chikungunya as well, in spite all your other differential diagnoses. Rashes can occur in your oral cavity, gingiva, sometimes the throat also, where you find difficulty in swallowing. So this is another important manifestation. About 20% of patients can get this sort of ulcers. And these are again other skin lesions that we have observed. This picture, patient has this necrotic type of a background. This is a hemorrhagic bullae. Sometimes you can see vesicular or hemorrhagic bullaes. These are sort of a tense, the vesicles here, very tensed vesicles. These are atypical manifestations where you always should suspect of this chikungunya with the current epidemic. So convalescent face rashes, those are acute face rashes, although again I want to stress you, there's no clear demarcation. This patient actually, these patients are not in isolation. They have multiple medical problems. This gentleman actually was waiting for the knee joint transplantation. He became very unwell. He couldn't walk. He thought it's due to the knee joint and involvement of the other joints with osteoarthritis. Just came to see, and I have asked to take the chair. He was seated, and stand up and come near me because he couldn't stand up either. Then when I observed him closely, I saw this. This is a very important physical sign where you call it a chick sign. So this is very important. Now this is a very common word also among this medical fraternity these days. So this same sign can have pigmentation, and also there might be peeling of rashes. The people who see patients, it's very important. Sometimes you are left up with slight peeling in your nasolabial folds. This rash and pigmentation might not be present in all patients. Now here the young girl is just like pimple coming up your nose tip, and here again slight pigmentation in the nose here. Along with this, you can have some sort of a dense the discoloration of your cheeks as well. If you are very fair, they become very pink, or if you are dark, it can appear as melasma. So I think the points that we learn, our clinical observation while taking the history is very important. Here again, this nasal pigmentation in different variant, and this patient has the cheek pigmentation as well. So this is the hypermelanosis. I think it's something very bad because this can persist. You can have hypermelanosis. Actually, this picture, all the other pictures are from patients with consent, but this is from the net I took. You can take this hypermelanosis also. And here, I think this news is not good for us. This pigmentation can persist even after 3 to 6 months. So the fair, beautiful people should be alert, isn't it? You are lucky, the rashes will go off. If not, you can end up with this sort of a persistent disfiguring. And again, this discoloration is important. The hand, you can see after the resolving of rash, the skin has got peeled off. And again, the next picture, the patient we had, again, she had some the histories of radiculopathy. She had done MRI, and during the last few days, she couldn't walk, so that she came with us to see. When we observe, you can see this pigmentation as well as small scaliness. So her acute deterioration is due to this chikungunya and possible arthritis. So other manifestations, this is, I think Dr. Athauda also have mentioned, this is very important manifestation. Now at least we know regarding these things. Patient comes with bilateral leg swelling, very erythematous and very painful skin. We tend to treat them for bilateral cellulitis with antibiotics, but late only we realize this is due to the chikungunya. Along with the joint involvement, you can have skin involvement. Sometimes you can get erysipelas type of a rash also, so that the gabapentin also has a place for severe neuropathic pain. So I'm sure people seeing these patients might have got many patients with this severe pain in the legs. And this is the same thing, delayed presentation. This patient had come the early months we have detected chikungunya, April. This lady, initially these cases we found in Colombo. This lady was working in Colombo. She came with joint pain with a background history of fever about 2 to 3 weeks back. So here, patient has delayed arthritis, leg edema, and you can see this skin pigmentation. So it's very important to observe and examine these patients to find out why exactly the cause. This is also again the skin manifestation which we also didn't know. This is a lady, 80-year-old lady with a depression and dementia. She was very unwell. She didn't eat and she has slight fever, not very convincing, but the daughter has got chikungunya. So we were thinking any infection which is causing her deterioration in the baseline dementia or depressive states. All the investigations were normal, a part of high CRP PCR, PCR and ESR, cultures were normal. When she discharged after 2 weeks, the daughter sent me this picture. It's type of a melia, type of a rash. It's a small vesicles appear. So again, manifestations of chikungunya, but this type of rashes are not very common. And when it comes to pregnancy, pregnancy can complicate but what we say is there is no transplacental transmission of the virus. If you get chikungunya at the latter stage of pregnancy, closer to the delivery, the child can get chikungunya. In fact, like Dr. Nilanthi said, I'm also a victim of chikungunya in 2006, where I was a registrar at Kalibovila teaching hospital, and I was pregnant, and then I had to undergo an emergency section due to the fetal distress. So chikungunya, the pregnant people, you should always very vigilant and careful. So maternal infection near the time of delivery may carry increased risk to mother-to-child transmission, and that time many babies had fetal distress due to this viremia in the mother. So this is neonatal chikungunya. Still you see the same rashes you see in adults, but this is the children can have long-term neurological sequelae with these are fetus infected with chikungunya. So severe manifestations, these are the very bad manifestations where we don't like much. These are pin-like lesions where patient has skin blistering, erythema, and widespread skin involvement. So you can see what a spectrum you can get with these chikungunya viruses, especially with these new strains emerging. So when you come to the management of skin lesions, self-limiting most cases, but rehydration, rest, your steroid cream, small dose of steroids, and emollients, antihistamines, analgesics can be helpful. But if you think your skin problem is very worse, you can always get your dermatology colleague's opinion. So this is our case that we have encountered. This is a patient, 68-year-old, with vascular risk factors, admitted mid-May to our unit, presenting with fever, arthralgia and myalgia, along with bilateral lower limb swelling. So this is the rash. After admitting to the hospital, we have seen these rashes appearing. It's somewhere, it's a sort of a plaque-like lesions in the legs, and it spreads. Here you see, then somewhere else, patient was very ill day by day. Patient is getting ill. He cannot get up from the bed, along with evidence of acute kidney injury. So this is the worst stage rashes. These rashes appearing all over, it started to come as hemorrhaging. So at that point, actually from the beginning we were taking our dermatologist opinion also. So we have arranged the skin biopsy, and then along with other investigation, chikungunya IgM antibody was positive. And since anyway your biopsy will take some time to come, you have to think what to do, because we are having this ill patient. We have concerns of the management. We don't know, because a lot of people ask, what is your evidence of treatment? What I want to stress is there are no proper evidences. As tropical countries, we clinicians should get together, see the case histories, see the case series, do the genomic analysis, and we have to find the treatment for this sort of a varying cases. So this is actually this is a histology report. Thank you, Dr. Palita Ratnayaka, because he said this is something new. He also went through the literature, and this skin biopsy points more towards chikungunya. So here, anyway, the diagnosis is a challenge. Early stage chikungunya PCR, it's not freely available, and chikungunya IgM, again after 6 to 7 days, you observed that, and in between patient has immune suppression. You don't have your antibody response because of ongoing viremia. So these are the true histology pictures of our patients, and I'm very grateful for sharing these pictures with us, Dr. our pathologist. You can see basal melanin pigmentation, transepidermal migration, and also the cleft. Sorry, I think it does. So this is the, anyway, this is the study. We saw what we just went through the case histories, and what it shows is immunoglobulin therapy in a patient with severe chikungunya fever and vesicular bullous lesion. The first reported case for IV immunoglobulin for skin lesions, but for neurological complications, people has used IV immunoglobulins. The treatment dose was 0.5 kilogram per day, and then they have noticed the complete recovery within 10 days. So after discussing with my co-colleague Dr. Sunil Bowattage and along with our dermatologist, we also carried out with this management with immunoglobulins 5 days along with other medication, and 2 hours there's a problem with slides, I think. Right, sorry. So what you can see, the improvement following IV immunoglobulins, actually the redness has improved and spreading of rash has halted. So, and then patient was became better, so he was able to go home. So it was something that we managed. And then we think of atypical fatal cases. This is a Venezuelan experience, atypical and lethal cases in the Western Hemisphere. What they have seen is, again, they have described 3 case histories. The first gentleman, again, coming with fever, joint pain. What you see in the first picture, it's like actually we have many different differential diagnoses for this picture. So for but all the cultures were negative, but his ESR high, CRP high, procalcitonin high. That's a challenge in thinking management. In a very short time, patient deteriorated in spite of the best care in the resource-rich settings. But later, the PCR, real-time PCR became positive. This lady also, again, coming with this facial rash. You can see this chick sign here. So she also went into refractive multi-organ failure in a short case. This patient has survived with, they have tried steroids here in this patient, excluding the possible underlying infection. So managing these fatal cases are always challenge. You know, you can't send for, you have to wait until 6 to 10 days for antibodies, and it is also available in the private sectors. And viremia, we don't have kits to find out viruses. The biopsies will take time. So always your anticipation and your vigilance and your knowledge of these cases are very important, and management in the patients in acute setting. So this is the lost battle from our side. This gentleman actually 2 weeks back, he is a 65-year-old gentleman, come with typical history of arthralgia, myalgia, a very initial rash, but during the very few days, patient went into acute renal failure. This rash was spreading all over, and then although we shifted to the ICU, we couldn't survive this patient. So I think the importance of this side of sharing knowledge is we get to know what's going on, and we can offer the best care of these patients. So these are my take-home messages for you, ladies and gentlemen. Skin is not just a window to chikungunya. Symptoms may vary from maculopapular rashes to vesicular bullous lesions. Can cause severe life-threatening skin manifestations. Early recognitions of cutaneous signs aid in timely diagnosis, guide severity assessment, prevent misdiagnosis, especially useful in atypical and afebrile presentation. Along with that, I would like to conclude my talk I would like to thank Dr. Krishantha Jayasekara and Council of Sri Lanka College of Internal Medicine and Professor Arinda Dharampala and the Council for arranging this event. My sincere thanks to my patients who are obliged in sharing these images and my medical team, Ward 2029, for their supportive role, as well as special thanks to Dr. Dasun Sandeepan for helping out with the slides. I hope this session has highlighted the importance of looking beyond the obvious in chikungunya, especially when it comes to the skin. Thank you very much.
Thank you very much, Madam, for that very informative presentation. Up next, we have Dr. Sunil Bowattage, Specialist in Internal Medicine at the National Hospital, Kandy. He will discuss the neurological implications of the chikungunya in his presentation on chikungunya as a neurotrophic virus. Over to you, sir.
The topic is chikungunya virus as an emerging neurotrophic virus. And if you get the literature at the moment, traditionally it is not considered as neurotrophic virus. But it's very unfair when going back to the history. Chikungunya outbreak in 2005-2006 and 2024-25, there are a lot of case report, lot of neurological case, and also a lot of neonates, lot of infants, and during pregnancy, lot of probably neurocognitive impairment, delay of the neurological development in the young, suggesting it is neurotrophic. And today, my first minutes I might ask is to re-evaluate these documented cases, why it is not considered as neurotrophic, but there are enough evidence when you are looking at the case histories, it is neurotrophic. So in this instance, I have just reviewed the bit of a major outbreak happened in the Reunion Island and the India in the 2004 and the 2005. Probably the 1/3 of the probably Reunion Island people affected with chikungunya virus. Population is less than 1.2 million, and of that probably probably in the 2005 and 2006, 1/3 of the population affected, roughly about 38% of the population, and there were 275 deaths. And if you look at the death, large number of due to the atypical presentation, including the neurological manifestation. And say some improvement in this epidemic in the 2024-25, there are less than 50,300 cases, and there were 20 confirmed deaths, and 37 days under investigation. There's a probable cause is the chikungunya. Again, when you are looking at these severe cases and the mortality, large number of the cases are due to atypical presentation, maybe to the pneumonia and probably due to the neurological manifestation. And same we have the parallel to the same, probably the identical serotype identified in 2005-2006 in India. Mainly the affected are the Nicobar Islands and the Andaman Islands and the other part of India. So there are more than 300,000 cases, it's more than 3,000 confirmed death due to chikungunya. So most of these deaths are again we are evaluated, they are due to the atypical presentations. And 2005 and again there's a large number of cases reporting and with a significant mortality. And interestingly, if you see the case reports, the 2000 and the 2005, it's mainly it's affecting the Andaman and the Nicobar Islands, but this epidemic, luckily, no case report from the Andaman and the probably the Nicobar Islands, but large number of cases from Maharashtra, probably the Samya. It's a large majority of case from the Maharashtra and the probably the so that we when you evaluate in this case is very important thing. Why suddenly? Suddenly because this with the 2004 to 2005 and there's about 90 year gap. That's about the work. If you get the India, it's mainly the chikungunya is a bit of endemic. But in the 2004 and the 2006, we experienced a large number of cases, probably due to this emergence of new mutation, Indian Ocean lineage. Again, this is not the new real. In fact, this the new mutation detected in 2006. But for probably more than 15 years, but it was a bit silent. Suddenly, it emerged as a bit of a new sort of a bit of an epidemic. So they might ask, when you are evaluating all the Nicobar Islands, the Indian cases and the Reunion Island, so more than 70%, 75% the mortality amount, more than 70 years. So there's age is a bit of an independent risk factor for a severity and the mortality. And the neonates, infants, pregnant mothers, when they get the disease, they get the severe disease as well as the high mortality. And also it's not the severe disease and high mortality observed in the patient with diabetic, hypertension, cardiovascular disease, kidney disease, COPD, CHCD, and patient among immunocompromised. So same way, when you evaluate the patient, there is a significant number of patients managed in HDU and ICU were due to the CNS involvement. And neurocognitive impairment noticed in neonates and infants. And when infection occurred during pregnancy, cognitive impairment and the delayed neurodevelopment of fetus noticed irrespective of the active infection in the fetus. So that's the probably, when you are evaluating these cases, there are enough evidence to support that chikungunya virus is neurotrophic. But that's to see whether when you are with the meta-analysis or systematic review of all the cases, neurological cases published till 2018. So if you see, there are more than 1,800 cases reported with the neurological complication for this particular systematic review. So they have considered only the 80 case report, and of that, some are due to the vertical transmission, some are due to the mosquito vision. So there are more than 75 case control studies for this thing. So this 80 publication, so more than 560 cases. So when you evaluate, we can publish the case of the encephalopathy, myelopathy, encephalomyelopathy, myeloradicopathy, neuropathy, ocular, various neurological complications. So neurological manifestations are not uncommon in patients with chikungunya. If you see the literature, meningitis, meningoencephalitis, meningoencephalopathy, flaccid paralysis of lower limb, seizures, cranial nerve palsies, stroke, sensory neural hearing impairment, cerebralitis, optic neuritis, uveitis, both granular matters and non-granular matters, myelitis, Guillain-Barré, carpal tunnel syndrome, ADEM, all these things are well described. And probably in our epidemic also, we notice a lot of patients with these complications. And when you are with the current epidemic 24-25, we see more and more cases with the atypical presentation and more and more cases with the neurological complication. So this is a Pune, Maharashtra. So far for this year, more than 5,445 cases with atypical presentation, including the neurological manifestation. And this particular epidemic is more thing is we see more and more severe thrombocytopenia. Very unusual. It's like a dengue. Most of the cases we think due to severe thrombocytopenia, thinking it is dengue. Also, when you evaluate the patient, most of the patient end up with a bit of a leaky, and sometimes maybe severe thrombocytopenia associated with the bleeding. So this is the situation in the Maharashtra Pune hospital. We'll voice of the
A newly
Pune hospital.
mutated Chikungunya virus has wreaked havoc across Pune. This alarming variant is reportedly to have infected over 2,000 people and is presenting life-threatening symptoms which have never been associated with Chikungunya before. Traditionally known for joint pain and fever, Chikungunya is now causing alarming new symptoms such as blackened nose, a first in Chikungunya cases. More disturbingly, many patients are experiencing paralysis. Adding to the confusion, this variant is now mimicking dengue by showing symptoms like fluid accumulation in lungs and stomach and dangerously low platelet counts. With over 1,000 cases seen in recent weeks and 30 new cases daily, doctors are overwhelmed and scrambling for answers. Pune's top infectious diseases experts are urging the National Institute of Virology for immediate intervention. With the situation rapidly worsening, doctors are advising vigilance and early testing. As the city battles this new variant, the need for rapid response and national expertise has never been greater. Stay tuned for more such news and updates. I am Anam Sheikh from.
So that's the situation in the public Pune. There are large number of cases with the atypical presentation.
A newly mutated Chikungunya.
And we can collect a lot of information for the Pune hospital. The Pune hospital, there were probably 117 children admitted to the Pune Pediatric Hospital from June 2024 to September 2024. So out of 117 patients, 36 patients required ICU care. So when we are evaluating these 36 cases to manage in the ICU, among severe presentation, majority of the children had neurological complication, roughly about 60%. So when they present, the majority of the patients are due to neurological complication. So of that, we have published 20 patients present the seizures, 7 patients present the drowsiness, 16 patients present the irritability, and 14 patients present the meningoencephalitis. And some of the patients, about 6 patients end up with severe hypotension and the shock, 3 patients end up with severe liver failure, and 1 end up with the liver transplant. And 12 patients end up with a severe respiratory distress. And this 36 cases, 2 died due to the meningoencephalitis and myocarditis. And the 3 patients end up with the severe thrombocytopenia, and the 2 cases end up with the HLH. So all these suggest with this new mutation, there are more atypical cases and more probably the severe cases and the mortality with the in the Pune. But when you come to the current situation in the Sri Lanka, unfortunately they have recognized the major outbreak in 24-25, and still probably we have not probably identified the atypical presentation and the mortality risk. See, so up to this year, March 2025, only the 175 cases were reported. Partly we are responsible because we are not notifying the case. Large majority of the cases are probably managed in the outpatient or maybe in the private sector. They are not probably being notified. Even the atypical patients presentations are not being notified, so that's why they are not given. Usually, if they are, we also see a lot of probably atypical patients, neurological manifestation, skin manifestation, fatal cases. Probably we have to notify this, otherwise we can't with the vigilance of the epidemiology department, and the preventive measures will be implemented. And chikungunya is not probably the acute or the bit of a subacute illness. Are a very important study in the Brazilian study in 2023. The Brazil, you get the bit of a chikungunya in probably 2014, the first chikungunya case, and there's a major outbreak in the bit of a 2023. So they have a bit of a 150,000 cases followed up. When you follow up, actually, the first week mortality is 8 times higher than the non-infected. And probably the 3 months still the mortality is 2 times higher than the non-infected. So what it indicates, so they need a bit of a extended healthcare support. It's like a COVID. We are just concerned about the patient with the arthritis, skin rash, probably maybe the first week, 2 weeks. Not that large majority of the chikungunya patient, they are elderly patient, sometimes immunocompromised with the other comorbidities. Large number of patients died due to sometimes maybe pulmonary embolism, sometimes maybe MI, stroke, or sometimes maybe they are diabetic or hypertension. They died due to the associated metabolic complication. So that's what the Brazilian study shows. They are mortality, though usually if you get the mortality, it's less than 1 per 1,000 life. But if you see the long term, so probably the mortality is more than that because of the unrelated probably cardiovascular death. So when you are going through the case histories, mainly the diagnosis of the CNS infection, when a patient presents with the maybe history of a fever and the CNS presentation, first thing you have to suspect is when you are doing the full blood count, you will see the severe lymphopenia. So the eye-opening thing is when the patient comes with the surrogate marker is a severe lymphopenia. Otherwise, when the patient comes with fever, headache, seizures, it can be due to any other viral infection. But the surrogate marker is a severe lymphopenia. So when these see the acute stage, probably the Chikungunya PCR is not available, but day 5, day 6, probably the IgM antibody maybe is positive that it can maybe the diagnosis toward the probably the CNS infection. So the most important thing is a CSF study, including the again PCR, because of the lack of the availability of the PCR. In the first week, most of the cases we can't confirm the diagnosis. When you are doing the MRI scan, they get an unspecific signal change in the maybe the paraventricular areas, periventricular areas, and the EEG may be a bit of a supportive, where the gold standard to diagnose and confirm is a bit of a PCR. It is expensive. Most of the cases we can't confirm the diagnosis. So when you are going through these cases, what is the treatment based on the case report? Mainly they are a bit of a supportive. And when you are going through the cases, there are two types of a bit of a CNS involvement. First thing is a direct viral invasion causing the bit of meningoencephalitis. At other points, some of the patient due to the CNS involvement due to the immunological involvement. So most of the cases, there's a dramatic improvement of the IV methylprednisolone when you are going through the literature, and some will respond to the immunoglobulins. So some studies they are tried with the IV ribavirin, but with apparent improvement, but up to now there's no place for any antiviral treatment. And we are just see with our experience to share two cases present with the Chikungunya, probably the CNS involvement. This is 81-year-old gentleman, though he's 81, he's a very healthy, independent patient. He's a lone stand in diabetic, hypertension, dyslipidemia with independent ADL. He was driving his vehicle, and he presented the 2-day history of a fever, arthralgia, myalgia, and probably 1-day history of a progressive lower limb weakness. At times he's a bit confused. Yeah, it's only the mild fever and no admission, no seizures, but later on in the when the patient admitted the 2 bit of a loss of consciousness suggesting probably seizure. Examination patient was afebrile, GC assault 14/15, and there's a flaccid paralysis of the lower limb at the areflexia, and other vital parameters, blood pressure, lungs, they were controlled right. So initially when he was admitted to the hospital, as he was afebrile, later on he developed a bit of this fever while he was in the ICU. So that's why again when you are doing the full blood count, the surrogate marker is a severe lymphopenia. See the lymphocyte on admission until the day probably at 16 to 20 severe lymphopenia suggesting the Chikungunya, and it is confirmed by this. Luckily that time the PCR was available in our hospital, so that with the Chikungunya serum PCR was positive. So when you do the nerve conduction study, it shows a bit of a severe axonal motor neuropathy. So the neurologic opinion was taken, and opinion was just it's a managed as a sort of a atypical Guillain-Barré. So we start with the IV immunoglobulin first dose. Unfortunately, with the first dose of immunoglobulin, patient deteriorate with the low GCS, respiratory distress and recurrent seizures. So we intubate the patient and send the patient ICU. And they are patient in the ICU. Probably continues the patient deteriorate with the aspiration pneumonia and the septic sick, So the ECG changes and troponin suggestive bit of acute coronary syndrome with the heart failure, atrial fibrillation. Ultimately, patients succumb to the death on 23rd of June. So we most probably, though, we manage as a patient with the probably the atypical sort of the Guillain-Barré, probably the deterioration GCS fits. Probably it's a case of a probably again meningoencephalitis or maybe like a ADEM kind of thing. Unfortunately, we couldn't do the lumbar puncture or patient the MRI scan, and the most probably again it's a the Chikungunya associated meningoencephalitis. So I think the second case is also very important because you need a bit of a high degree of a suspicion to diagnose Chikungunya because age is the main, probably the risk factor for getting the severe disease and atypical presentation. This is 76-year-old gentleman, again long-standing diabetes, hypertension, dyslipidemia, ischemic heart disease, Parkinson disease, limited ADL following the left side ischemic stroke. He was admitted to the probably poor responsiveness and poor oral intake for 1 week duration. It's very common because the patient is a probably previous stroke and the multiple comorbidities. Anyway, he's some sort of a bedbound character. When you are coming with the 1 week history of a bit of this deterioration is cognitive this thing. So when you are inquire the patient, when his deterioration, he had the history of a fever. And there was no any respiratory or any other symptoms. Examination, he was afebrile. GCS so 12 out of 15. Pupil equal and react to the light. That's only the focal neurological examination suggesting the previous stroke. Bilateral plantar downgoing. Blood pressure, respiration, and everything was normal. So again, when you evaluate and see whether this patient, the surrogate mark is severe lymphopenia. Severe lymphopenia. So we thought whether the severe lymphopenia with the possibility of a Chikungunya on this patient. So when you are doing the serum IgM antibody, it was positive. Chikungunya antibody was positive. And so we did the lumbar puncture. So lumbar punctures, 3 white cell count, all were lymphocytes. And when the CSF protein was elevated, 93.6. Again, ideally, if we couldn't do the bit of a CSF PCR for Chikungunya, that's a gold standard test to confirm the diagnosis. So the lesson is, so this patient also we managed with the IV methylprednisolone for 3 days with the dramatic improvement of the clinical condition, and we continued 30 mg of the prednisolone for another 5 days. His GCS was improved, his mobility was improved, and with routine medication he was discharged on 22nd of July. So the lesson is Chikungunya and neurological complications are not uncommon. You need a bit of a high degree of a suspicion. So in our ward, probably more than 10-15 cases. Unfortunately, we can't confirm the diagnosis because MRI scans are not freely available, especially when you are acute state, when you are doing the CSF studies. So that we can't do the Chikungunya for the PCR. So somehow we have to implement, if you want to save the patient's life and improve the outcomes, the neurological complication. So the PCR facilities should be probably available in our hospital. So that's why if you get the WHO, for the WHO won, now we are in a sort of a bad sort of a Chikungunya epidemic. So being third world countries, they are giving the 3 recommendations. Be vigilant, do a bit of a case surveillance. And second thing is, they are recommending is improve your lab facilities, If you don't improve the lab facilities, you will not be able to pick up the disease in the early stage. This Chikungunya antibody, it will be positive on the day 5 or the day 6. If you don't confirm, it should be the PCR. So the lab should be improved, and you need a bit of a high degree of maybe suspicion, and screening is very important to identify the complicated Chikungunya cases. Thank you.
Thank you very much, sir, for that very informative presentation. And our final speaker for this session is Dr. Shifa Azher, specialist in internal medicine at National Hospital Kandy. She will take us beyond the usual by exploring how chikungunya affects other systems. Over to you, madam.
We have heard about how chikungunya affects joints, skin, the neurological system, and several a few other things were also mentioned. To start off my speak, I would like to elaborate on a case history which we managed about a month ago. This patient, a 60-year-old previously healthy male, was admitted about a month ago with a history of fever, myalgia, and arthralgia, and cough with loose stools of 2 days duration. While in the ward, he developed severe respiratory distress with pre-renal AKI, and he was transferred to MICU for respiratory support. And while during the investigations, we found he had a high viral load of chikungunya. PCR was heavily positive. HRCT test done subsequently showed there is bilateral low lobe consolidation with presence of pleural effusion. And subsequently, he was intubated, and later he developed secondary bacterial infections, and antibiotics were also commenced. Later on, we were finding it was difficult to extubate him, and subsequently we noticed that he was having limb weakness with bulbar weakness as well. One special point in this patient was he had diaphragmatic weakness as well, and this was associated with very high CPK levels, showing indicating that there is an ongoing myositis as well. With all the supportive management, the extubation attempt was failed twice, but then he was re-intubated, and subsequently he recovered gradually. While in the MICU, the nerve conduction studies were done, and that showed features of a Guillain-Barré, atypical Guillain-Barré picture was seen. In addition to that, during the periods of extubation, he was noticed to be confused and was irritable, and features of encephalitis were also seen. So therefore, subsequently he was treated with IVIG, and he clinically improved, and weakness of the limbs also improved. And furthermore, while in the ward, while in the MICU being treated, he was complaining of abdominal pain, distension, and there was vomiting as well. And the chest X-ray showed he had generalized abdominal tenderness. The chest X-ray showed air under the diaphragm, and GI perforation was suspected. And the surgical team, they did an emergency laparotomy, and they found that there was a sigmoid perforation with peritoneal contamination, and fortunately it was a sealed sigmoid perforation. That means it was a very minute perforation, and they didn't have to do any repair there. And the jejunum also was noted to be edematous, and the laparotomy was successful. While in the MICU, he was noted to have several other complications as well. He developed hypoalbuminemia, so electrolyte imbalances of various electrolytes, which were managed appropriately. In addition to that, he had thrombocytopenia, and later on he developed the HSV infection of the jaw, for which he was given IV acyclovir for 7 days. And he also developed, in addition to the neurological manifestations such as encephalitis, atypical Guillain-Barré, he had autonomic dysfunctions as well, resulting in episodic high blood pressure, tachycardias and bradycardias, which were managed appropriately. He was transferred to the ward after about more than 20 days of stay in the MICU, and during the transfer, the stables were vital. The GCS was 15/15, but he continued to have proximal muscle weakness of the lower limbs and distal muscle weakness of the upper limbs. Therefore, we we gave him a pulse of IV methylprednisolone, 3 doses, and with which he recovered markedly, and he was discharged home 2 days back, walking home. So that case illustrates what sort of multiple problems, the types of multiple system involvements a patient with chikungunya can get. And I would like to talk about a second case history. This is about a 45-year-old male who is an army camp chef from Diganar. This was managed in one of our medical wards, which was with a past issue of ASD, which was not relevant here. And he had 2 days history of low-grade intermittent fever. This was associated with arthralgia, mild headache, nausea, vomiting, right hypochondrial pain, and loose stools. He also complained of chest pain on admission. And then he became suddenly more ill with sudden retrosternal burning pain with autonomic features, which required morphine, but there was no SOB or radiation of the radiating chest pain. There was no travel history or in the history of insect bites. He was ill-looking and he had a bradycardia with hypotension. And in addition to that, he had mild right hypochondrial tenderness. There was no rash, jaundice, lymphadenopathy, or scar. WBC showed initial neutrophilia, which became normal later on. The platelets dropped to 38,000, which also improved later. CRP was 106, and that also dropped later. The liver function test showed a high AST and ALT and gamma GT level, showing a transaminitis with low albumin. The troponin I levels were elevated. The ECGs showed nodal bradycardia with a prolonged QTC interval. Echo showed an ejection fraction of normal ejection fraction, but with a right ventricular dilatation. Later, the chikungunya IgM was positive, and this patient was managed as a patient with chikungunya fever with myocarditis and bradyarrhythmia. He was given IV antibiotics and IV methylprednisolone pulse. 3 pulses were given as a treatment of myocarditis, and he even required temporary pacing until the rhythm stabilized, and he went home with full recovery. So by illustrating these 2 cases, and after listening to all the 3 previous lectures, we all realized that chikungunya is not just fever, rash, and joint pains. It is more than that. The learning objectives of this speech is to identify the systemic manifestations beyond joints, rash, and neurological involvement, and to understand the pathophysiology of severe systemic involvement, and to highlight evidence-based treatment strategies such as steroids and IVIG. Why is it necessary to talk about these things? Because as we all discussed so far by the other speakers as well, it's beyond the traditional triad. The traditional triad of fever, rash, and arthralgia is not the only manifestation of chikungunya. Recent outbreaks show to us that there are other systemic complications: cardiac, renal, hepatic, GI, endocrine, and several others. The WHO and the CDC also have recognized that these are labeled as atypical and severe forms of chikungunya. But while managing chikungunya patient, we need to bear in mind there is always a clinical overlap with dengue and other types of sepsis. So therefore, misdiagnosis and delayed treatment is possible. It's possible to miss chikungunya when you see multi-system involvement. Back to the basics. Just a few words about the pathophysiology of the severe disease. My colleagues have all mentioned about it. Just a summary of this. Initially, we do see direct viral invasion of various tissues. Myocardium, hepatocytes, renal tubules, and pancreas are the most commonly invaded tissues. In addition to that, there is immune-mediated injury with cytokine storm, resulting in high levels of cytokines, such as interleukins, tumor necrosis factors, and other cytokines. Also, there is historical evidence of vascular and endothelial dysfunction resulting in capillary leak, thrombosis, and in severe cases, you might even see DIC. So therefore, if you look at different systems, what about the cardiovascular systems? Myocarditis is increasingly recognized in epidemics, but it's often underdiagnosed. Not only myocarditis, they could get pericarditis, arrhythmias, and shocks. The laboratory findings, the available investigations we do have are ECGs and troponin Is. And if available, the BNP, the natural factors may also be elevated. Echo is actually which is freely available for us, which will illustrate presence of whatever the dysfunction, LV or RV dysfunction, and effusions in cases of pericarditis. The picture here shows the presence of a rim of pericarditis in one of our patients. Treatment options are actually symptoms based with oxygen, inotropes, and plus or minus steroids or IVIG in severe cases. What about the renal complications in chikungunya? In chikungunya, renal complications are fortunately rare, but most of the time what we encounter is pre-renal involvement, hypovolemia and dehydration resulting in pre-renal impairment, but intrinsic renal involvement also have reported in literature, such as acute tubular necrosis, interstitial nephritis, and renal impairment subsequent to rhabdomyolysis. Here again, the management is based on basic principles of management of fluid balance, monitoring the electrolytes, avoiding nephrotoxic, and when indicated dialysis. This is a slide illustrating, I'm sorry the slide is a bit crowded, where they had studied about 129 cases, and in those 129 cases, only 15 had kidney injury, and even in this cohort of studies, they had gone on to do renal biopsies where it had shown various types of glomerulonephritis, crescentic glomerulonephritis, focal segmental, and TMA, that is thrombotic microangiopathy, and various other things, membranous nephropathy also have been reported. But the good news is that they had not been able to find evidence of virus multiplying and remaining in the renal tissue. Right, what about the liver? Liver, it is very common to notice transaminitis, which we see in our wards. A lot of patients do have transaminitis. Some cases may progress to acute hepatitis and cholestasis. Important differential is whether it is dengue hepatitis or hepatopathy or drug-induced liver injury. The picture here shows the different types of mechanism by which the liver is damaged. Either it could be direct viral cytotoxicity or could be immune-mediated, hypoxic damage because following plasma leakage and ischemia, or oxidative stress, and another mechanism also have been postulated, such as induction of fibrogenic cascades. Here again, when there is liver involvement, supportive management and hepatoprotective measures. We heard that Dr. Bowattage said about even in India they had to go for liver transplant. When there is severe liver injury, one has to resort to those mechanisms, those measures, which are not available for us. What about the respiratory system? Can there be breathing trouble? Yes, not uncommon, rare, but can happen. You can get pneumonitis and ARDS. Again, it is common in patients with severe cytokine storms. The management is again oxygen, ventilator support, antibiotics for certain infections, and ICU care. Steroids and IVIG have been shown to be helpful in selected cases with ARDS. There is literature evidence to show this benefit of these measures in these patients. In this picture, this is from a case report where they had the first X-ray shows bilateral lung shadows, and they had given IV methylprednisolone for 3 days, and the second chest X-ray shows clearance of the lung involvement. What about the hematological involvement? Hematological involvement is common in chikungunya. As other speakers mentioned, lymphocytopenia is commonly seen. 60 to 90% of patients you see lymphocytopenia. In dengue you see a leukopenia where all cell lines will be low, but here you see the lymphocytes are markedly reduced in patients with chikungunya. So therefore lymphocytopenia can be used as a surrogate indicator to show that this patient has chikungunya, to suspect this patient has chikungunya. In addition to that, we could see mild leukopenia. Mild to moderate thrombocytopenia is a very common finding, and atypically you can get pancytopenia and even severe thrombocytopenia. And on examination can have hepatomegaly. Rarely you do come across patients with splenomegaly. Very rarely chikungunya can lead to DICs and HLH syndromes. Therefore, monitoring, hematological monitoring is very important to arrive at to pick up these things and to initiate therapeutic measures. What about the GI system? Symptoms like vomiting and diarrhea are not uncommon. Sometimes in severe cases you can have GI bleeding, dysmotility, ileus, paralytic ileus is not uncommon in patients with chikungunya. And rarely you can see perforation, as I illustrated in our first case. There was a GI perforation. When intestinal perforation is said to be common in ileum. Here again, the management principles are the same. Fluid balance, giving PPIs, antiemetics, and whenever needed to get surgical input. What about the endocrine manifestations? There had been reports of acute and transient endocrine manifestations such as stress hyperglycemia, thyroid dysfunctions, adrenal insufficiency, and syndrome of inappropriate ADH secretions. Then the treatment is by the usual measures, supportive measures by blood sugar monitoring, IV hydrocortisone when indicated, and fluid and electrolyte correction. What about ophthalmological manifestations? Ophthalmological manifestations are not uncommon. Eye surgeons will be able to tell us more about these things. In the acute phase, we do see patients with conjunctival injections, conjunctivitis, and photophobia. In the post-acute phase, there can be conjunctivitis, uveitis, and even optic neuritis and chorioretinitis also have been reported. So therefore, it is essential to look out for eye symptoms. In most cases, improve with treatment offered. So here, it is at this juncture, there's a need to talk about the special populations, vulnerable population. As stated by my previous speakers, pregnancy there is vertical transmission is said to be possible, particularly during the intrapartal period. So, and there had been instances of first trimester infection causing miscarriages also have been reported in the literature. The other population is the elderly populations and patients with comorbidities. As in any other illnesses, they have higher risk of systemic complication, longer post-viral fatigue, arthritis, and other complications such as infections. And immunocompromised patients they are prone to get atypical and severe diseases. Management of these special populations needs early identification, frequent monitoring, and avoid NSIDs, especially in pregnancy in third trimester. What about leaking? The often asked question is chikungunya associated with a leaking? Is leaking possible? So there's evidence to say leaking is possible in chikungunya. But at the same time, we do see patients with serocytes with chikungunya. So true plasma leakage is rare, but transient vascular leak can occur mostly in vulnerable population. And duration of the leak is not well defined. Therefore, we need to be vigilant about possibility of co-infection because it is the same vector which is transmitting dengue and chikungunya. Again, the mainstay of patients with chikungunya is to supportive care, avoid NSIDs in acute phase, and if dengue can't be excluded, whenever needed, steroids and IVIG may be required in indicated patients. When there's multi-organ involvement, to look for ICU care, and no proven antivirals have been of benefit. Vaccines is not widely available. There is a vaccine available which is used for lab workers and in selected populations. So therefore, the take-home messages relevant to chikungunya would be, in all patients with chikungunya, when you consider subclinical infections can occur in about 15 to 30%. And in some patients, it could be a self-limiting illness. Not everyone is going to get complications. Systemic chikungunya is a reality and not a rarity. Early suspicion saves lives in cardiac, renal, and hepatic and other presentations. And selective use of steroids and IVIG may improve outcomes in patients with severe manifestations. Therefore, there is a need for the physician to be aware of all these things, strong need for the physician awareness beyond the skin and joint. Clinical judgment, frequent monitoring, and tailored approach are the crux of care in the management of very ill patients. That is the end of my thing. Thank you very much for everyone, and thank you for my sir who helped me with the preparation of the slides. Thank you.